Imagine you're a patient and you are told that when you go into hospital, you might be given an intervention that a lot of doctors use routinely that may worsen your illness, prolong the duration of your stay, damage your kidneys, and may increase your risk of death. Well, you wouldn't want to have that intervention, would you? But that intervention is isotonic saline solution, an intravenous drip of salt water. And the curious thing is that there are loads of alternatives to getting this, but most doctors don't seem to be aware or are just disinterested in the science behind why saline might hurt the body. So this is a review of the literature on hyperchloremic acidosis and hyperchloremia that is iatrogenically caused by the administration of isotonic saline solution. Hyperchloremic acidosis. Does iatrogenic hyperchloremic acidosis worsen outcomes? Before I start, a quick disclaimer. What I'm going to talk about represents a literature review performed by me expressing my opinions on this literature. You may read the same papers and come up with entirely different conclusions. Regardless, it's important that I recognize that the work that's been put into these research papers was immense. It's really hard to do clinical research in the ICU. It's really hard to even follow up the patients. And I am not in any way criticizing individuals, societies, or institutions. I have no conflicts of interest to disclose. In this particular talk, I'm going to look at hyperchloremic acidosis. I'm going to start with a short history of this and then go on to a review of the literature of hyperchloremic acidosis and ask the question, does iatrogenic hyperchloremic acidosis cause organ injury? The first time I encountered the concept of saline-induced hyperchloremic acidosis was when I read this paper in 1999. This is a quarter of a century ago. 30 patients in each group in this study were assigned to a bolus of 30 mils per kilo of sodium lactate solution, that's Hartmann's or lactated ringers, versus saline, and measurements were taken at 30-minute intervals. And what's really impressive in this study, and you can freeze this picture if you want, is the significant drop in the pH and in the base excess, or the base deficit, over there on the left-hand side of the screen. Indeed, the fall in the pH and the base deficit strongly correlated with a rise in the chloride and the strong ion difference. And although this term was new to me at the time, it wasn't new at all. In fact, this concept of saline causing a narrowing of the strong ion difference goes all the way back to the work of Henderson in the 1920s. And he clearly demonstrated that the pH fell as the chloride level rose. And indeed, if you go back to the 1930s, it was clearly recognized that there was a problem with giving isotonic saline to patients. And Alexis Hartmann, who was a pediatrician in St. Louis, developed his own intravenous fluid that he called lactated ringers. In the rest of the world, they call it Hartmann solution, as an alternative because of the problems with the abnormal biochemistry that results from the administration of saline. And indeed, here's a quote from his paper. Lactated ringer solution may be given by any of the parental routes. It has almost entirely replaced the use of physiologic solution of sodium chloride or ringer solution, that's a different type of ringers, at the St. Louis Children's Hospital for the routine treatment of dehydration with or without the knowledge of coexisting chemical changes. And what I found fascinating was one of Hartmann's motivations in developing this particular fluid was the problem of hyperchloremia and persistence of acidosis in patients who were being treated with diabetic ketoacidosis, which was his clinical realm. Over the years, we've seen a large amount of publications that appear to demonstrate adverse outcomes from acquired hyperchloremic acidosis, and that happens from giving saline to patients. In the previous tutorial, I described how giving each liter of saline equates to giving 50 millimoles of hydrochloric acid to the patient. So we had all these papers that showed reduced splanchnic blood flow, reduced renal blood flow in GF4, possible reduced gastropyloric activity, resulting in prolonged gastroparesis post-op. And of course, it being a hyperosmolar solution, it does result in a slower time to first urination in volunteers. There was also a potential signal that there was an increase in mortality in patients who developed hyperchloremia, and a whole bunch of papers that looked at different levels of increase in the chloride, usually above 110 millimoles per litre, and apparently increased risk of mortality in a variety of scenarios, but mostly in critical care. It seems that chloride removal is a significant function of the kidney, and one of the first things that happens in acute kidney injury is the urinary strong iron difference increases. And that appears to be due to the inability of the kidney that is failing to excrete a chloride load. And so the first thing that you see in acute kidney injury is hyperchloremia. We don't really know whether this is the chicken or the egg, but we do know that once the chloride goes up, the GFR falls. It seems to be associated with oliguria, and it may well be that hyperchloremia induces a renal injury. Conversely, one could argue that a renal injury is manifest initially by hyperchloremia. Volume resuscitation with saline versus balanced salt solutions may result in more coagulopathy and platelet dysfunction. We do know that hyperchloremic acidosis may impair gastric function, and hyperchloremia results in more postoperative nausea and vomiting. So that's the reason why most anesthesiologists don't use isotonic saline in their clinical practice. After it became apparent in the early 2000s that there may be a problem with saline, particularly with hyperchloremia, a lot of hospitals decided to change from using isotonic saline solution for resuscitation of their patients in critical care and indeed maintenance fluid to chloride poor solutions. This particular study was a prospective cohort trial from a hospital associated with the University of Melbourne. And they did this study over 2 years. The first year where they just measured the outcomes of patients who were given chloride-rich solutions. Then there was a phase where they essentially gradually got rid of the chloride-rich solutions for more chloride-poor solutions, and they replaced them with lactated ringers or plasmolite and a different version of albumin. And then they looked at various parameters, including how sick the patients were, what their mortality rate was, but they were particularly interested in whether there was a higher risk of needing renal replacement therapy before versus after the fluid switch. There was no question that after the intervention period, after the switch, the amount of chloride the patients got reduced significantly from somewhere in the region of 700 millimoles per patient to about 500 millimoles per patient, and that is about a 200 millimole difference what you would have in 3.5 liters of saline. There was also, of course, a reduction in the amount of sodium, because if you go from 154 millimoles of sodium to 140 in plasmolite, 130 in Hartmann solution, there's a big reduction as well. So the amount of sodium per patient dropped from 750 millimoles to about 625. Did this make a difference? Well, apparently it did. Between the two periods, it appeared that following the removal of a lot of that chloride that patients had been getting, there was a reduction in the requirement for dialysis or other forms of renal replacement therapy. So this was good institutional information. It was in some ways circumstantial data, but it seemed quite compelling. A year later, in 2013, this paper was published by Stuart McCluskey and colleagues from the University of Toronto. This was a large retrospective cohort study that looked at patients who had undergone surgery at the University of Toronto hospitals over a 5-year period, 2003 to 2008. The patients that were excluded were those who were having cardiac surgery, those who had pre-existing renal disease, or patients with preoperative hyperchloremia. And what they were looking for was patients who had acquired a plasma chloride level in excess of 110 millimoles per litre within 2 days of surgery. And then those patients were compared with a propensity-matched control group whose chloride was within normal limits. So they had about 5,000 patients with a chloride of 110 or higher, and just about 4,300 who were non-hyperchloremic. 22% of all patients had acute postoperative hyperchloremia in excess of 110. There was a significant increase in the risk of death within 30 days for this cohort of patients. That was 3% versus 1.9%. So that's just over a 1% increase in the risk of death, and there was an average, a 1-day increase in the duration of hospital stay. the hyperchloremic patients were more likely to have postoperative renal dysfunction. Using logistical regression methods, hyperchloremia was independently associated with an increased 30-day mortality with an odds ratio of 2. This is a scary picture from the paper that places the inflection point of mortality versus chloride at 110 millimoles per litre. From this point onwards, you can see there was a direct correlation between the risk of death and the increase in the plasma chloride. What I didn't learn from this paper is whether the patients with hyperchloremia had more blood loss and more transfusions, because physicians are less likely to mix lactated ringers with blood products for fear that the calcium will clot the blood, because the highest risk was in patients undergoing laparotomy. So it is possible that hyperchloremia in this study reflected higher risk, more complicated surgery in patients who were likely to do badly. This is a picture of the rapid infuser that is kept on standby in our obstetric unit. Note that you have no choice but to prime the system with saline. Also, if the patient receives several liters of sodium lactate solution, even if they haven't had saline, they will inevitably incur a rise in plasma chloride. So irrespective, patients who get a lot of fluid that either is saline solution or lactated ringers Hartmann solution, they will see a rise in chloride. And so the rise in the chloride might reflect the degree of resuscitation that a patient required because they were really sick. So this issue needed to be resolved. Perhaps it was the blood loss that was the issue and a calcium-free fluid had to be given. To address the question, Andrew Shaw and colleagues looked at plasmolite versus saline in perioperative care. The investigators at Duke University used a large claims database to evaluate outcomes in patients who had received either saline or plasmolite on the day of surgery. There were 31,000 patients who received saline, but fewer than 1,000 who received plasmolite. Again, propensity matching took place and a variety of major and minor complications were addressed. The cohorts had to be matched because there was a significant imbalance between the two groups. For example, emergency care patients and elective patients in the full database had different fluid strategies. So eventually around 3,000 patients with saline were matched with 1,000 patients who received plasmolite. The patients who received plasmolite had fewer deaths and complications. The in-house mortality rate was 5.6% in the saline group versus 2.9% in the plasmolite group, which is astonishingly high, whatever patients they chose. There were far higher numbers of complications in the saline group versus the plasmolite group, and the plasmolite patients were significantly less likely to develop sepsis, need a blood transfusion, or be dialyzed. Similar data were reported in critically ill patients who had evidence of sepsis and received fluid boluses. There was a direct correlation between the rise in chloride and mortality. Indeed, a large cohort-matched follow-up study in sepsis by Shaw demonstrated that for virtually every measurement, patients had better outcomes with balanced fluids versus those given saline. So at this stage, in 2015, we have quite a lot of data that suggests that saline may be a bad choice of fluid to give critically ill patients, particularly with sepsis, high-risk patients who are undergoing operations, and possibly patients coming into the emergency room. But association is not causation, and there needed to be a series of randomized prospective clinical trials that looked at large volume saline versus balanced solution resuscitation in each of these avenues. The first of these trials that we will discuss looked at saline versus balanced fluid on acutely ill patients in the emergency department. A group from Vanderbilt conducted the SALT-ED trial, and that was published in the New England Journal in February 2018. And this looked at balanced salt solutions versus saline, balanced salt solutions in this case being either lactated ringers or plasmolite, in acutely but not critically ill patients. Those are patients who arrived in the ED and it was thought that they needed some fluid resuscitation. They didn't get a lot of fluid. The mean was only 1.5 litres. The median was about a litre. But it was a huge trial. There was over 13,000 patients, and the best part was that there was no contamination between the groups. Now, the primary endpoint was hospital-free days by day 28, which was a surrogate for morbidity and mortality. And this is one of the real problems with critical care and acute care and really medicine in general. If you're trying to do a capture-all study for patients coming into the ED, what do you use as your endpoint? Because pretty much anything can happen to these patients. So they came up with this surrogate endpoint, 28-day hospital-free days. And they also had a bunch of secondary endpoints that looked at acute kidney injury, renal dysfunction, renal replacement therapy. So let's have a peep at the electrolytes in these patients. There were 6 panels that addressed the electrolytes in the first 72 hours. The top panel, sodium chloride and urea. The bottom panel, potassium bicarbonate and creatinine. Now you can see that saline results in a rise in the sodium and the chloride and a drop in the potassium and bicarbonate. This is presumably both dilutional for both potassium and bicarbonate, but also likely mild metabolic acidosis associated with the saline. There is an interesting rise in urea and creatinine late. That's at 72 hours. Of course, it takes a while for creatinine to rise, and remember that if you give fluid, it dilutes the creatinine. But this was of interest that creatinine seemed to bump a little bit. There was no difference in hospital-free days over 28 days, so that didn't turn out to be a particularly useful measurement. But there were different renal outcomes, and I think it's worthwhile to consider the odds of a major renal event were significantly higher in the saline group, particularly if the plasma chloride exceeded 110 millimoles per litre. So in summary, nice study, weak endpoint, small signal that saline may be harmful, certainly no signal that saline versus balanced salt solution is better in the ED. The ED in my hospital continues to use saline. Here is the final outcome table. Note the extremely low mortality rate of 1.5% and the higher rate of renal injuries within the first 30 days. The numbers are small, but it was statistically significant. The next question, though, this group went on to ask was, are balanced crystalloids better than isotonic saline in critically ill patients? This was the SMART trial. That's the same group from Vanderbilt, and a similar study on critically ill patients, but at different magnitude. There were almost 16,000 patients recruited from 5 ICUs in this study. They were randomized to saline versus balanced salt solution. The primary endpoint was major adverse kidney event within 30 days, and that was a composite endpoint of death, dialysis, or prolonged rise in creatinine. There was a bit of crossover in that both groups got a little fluid from the other side, and the cumulative volume of crystalloid was unbelievably low, not even 2.5 litres after 7 days for the study fluid. It's hard to imagine that you're going to show devastating toxic effects of chloride or even sodium at that level. But there was a decent increase in the plasma chloride in the saline group, with a modest fall in bicarbonate demonstrating mild metabolic acidosis. And there was a 1% absolute increase in the incidence of major adverse kidney events at 30 days. So this was a positive trial. Using their surrogate endpoint, they were able to demonstrate a negative outcome associated with saline. This is the odds and sods graph, and I want to draw your attention to 2 parts. The first is that for sepsis, there was a strong signal supporting the use of balanced solutions, consistent with the previous study. The second is for patients who had previously received renal replacement therapy. Again, statistically compelling evidence supporting balanced solutions. What interests me here is that in most hospitals, those patients who have a history of end-stage kidney disease or known kidney injury are usually treated with saline because of the often nonsensical fear of the potassium content of balanced solutions. Similar data were reported in a secondary analysis of the SMART trial in the Blue Journal in 2019. In this particular study, about 10% of the SMART ICU database patients, or 1,641 patients, were admitted to medical ICU with sepsis. These are the outcome data, and I want you to focus on just two factors. The 30-day in-hospital mortality, which was significantly higher, nearly 5% higher in the patients who received saline, and additional adverse renal outcomes, in other words, acute kidney injury. There was approximately a 4.5% increase in the risk at 30 days. The 60-day mortality was not statistically significant. A similar study published in November 2023 looked at balanced salt solutions versus saline for fluid boluses of children with septic shock, and they found a 12% absolute risk increase of acute kidney injury in sepsis with saline. What about patients with diabetic ketoacidosis? These patients typically get a lot of saline. Over the past decade, 12 to 15 years, there have been a bunch of studies that looked at the clinical effects of giving balanced salt solutions versus saline to patients with diabetic ketoacidosis. The SMART trial authors looked at their data and did a secondary analysis of diabetics who are ketoacidotic who were treated with saline versus balanced salt solutions. Now the numbers are small here, so you need to be a little bit careful, and this is a subgroup analysis. There were fewer than 100 patients in each group, but they did get a significant amount of fluid, more than 2 litres in the ED and then a couple more litres in the ICU. So between the ED and the ICU, you were up at more than 4 litres, up to nearly 5 litres in the saline group. And this is consistent with what we see in our clinical practice. And there was a clear signal that the acidosis was much slower to resolve in the patients who were given saline. And interestingly, the time to discontinuation of insulin infusions was longer in the patients who were given saline versus those who were given balanced salt solutions. Now, clearly, the type of patients who come in with DKA are young patients. They're going to get better anyway. The acidosis will resolve eventually. But that's a significant amount of intervention. Beds in critical care are quite limited in availability, and the longer a patient has to stay in the ICU or the high dependency unit because they're on an insulin infusion or because they're acidotic, there is an opportunity cost that excludes other patients from that bed during that time who may need critical care. So I think this is a significant factor that we need to take into account when we're looking at diabetic ketoacidosis, and this is not new data. This is a study from 2021 looking at saline versus plasmolite in severe DKA. It was called the SCOPE DKA trial, and it was a similar study, and again it showed the same outcomes, more rapid resolution of acidosis in the patients given plasmolite. Another study from 2012 from Australia looking at plasmolite versus saline showed again less hyperchloremia in the plasmolite group and more rapid resolution of acidosis in that group. Another study from 2011, same story, more rapid resolution of acidosis and less hyperchloremia in patients given plasmolite. So now we have several studies that have shown more rapid resolution of acidosis, so better outcomes in patients given plasmolite versus saline. To date, no study has demonstrated that saline is superior to plasmolite 148. And this is curious because everywhere around the world, every hospital has a protocol for the management of DKA. And in most of those hospitals, they are telling doctors to use saline, which on the basis of published data is an inferior product to be resuscitating patients with, and then plasmolite, and probably lactated ringer solution. So by the mid-2010s, we had some good circumstantial evidence that isotonic saline may be harmful, but most doctors were still using this fluid. So it was time to do a good, high-quality randomized controlled trial. To do the trial, you needed to have patients who were relatively sick who would get a large volume of intravenous fluid. they need to be potentially harmed by that fluid, i.e. critically ill patients or patients who are having surgery. There had to be a treatment or detriment effect, i.e. there needed to be a chloride level of above 110 millimoles per litre, and the outcomes had to be measurable. Before proceeding, I think it's worth looking at the problems associated with doing clinical trials on intravenous fluids. The first thing is you need realistic endpoints. It's almost impossible to believe that modest amounts of fluid leading to mild hyperchloremia will increase mortality. It just isn't going to happen. We've reached a point where patient outcomes in intensive care are pretty well set. Anything that we bring in at this point in time will likely reduce the length of stay, reduce morbidity, but the people who are going to survive are likely to survive, and the people who are going to die are likely to die. And perhaps some of them will die late because of interventions, but they're rarely measured in clinical trials. The endpoints of trials must be consistent with current and not historical patient outcomes, or the study will be underpowered. I can tell you that the type of patients in the ICU now are different than they were 5 years ago, 10 years ago, 15 years ago. So if you're using outcomes data from 10 years ago for your trial today, it's not going to work, because if you had a 35% mortality rate in your ICU for example, ARDS or sepsis 10 years ago, and you power a study based on that, but your real ICU mortality rate today is 27%, you need a 8% reduction in mortality just to get where you are. And it's just not going to work. And this is a real problem. The other thing with fluids trials is that if you're going to do a trial in fluids, you need to be giving patients some fluid. Previous studies that I've shown you gave stunningly little fluid, but still had a signal. Following these various trials, a couple of very large clinical trials of fluids, saline versus balanced salt solutions in critical care were undertaken. The first one was down under in Australia, and this was the PLUS trial, plasmolite versus saline. The patients who were recruited into this trial had to be over 18 years of age in 53 ICUs, and the trial was conducted between 2017 and 2020, and fluid resuscitation was judged to be necessary. Patients' expected length of ICU stay had to be 3 days, and fluids were given in de-identified bags. For up to 90 days, the patient had to get this fluid for all therapy, which meant that resuscitation fluid was used as a maintenance fluid in this trial, for better or for worse. The outcome data that they looked for was death at 90 days for any reason. Secondary outcomes were peak serum creatinine during the first 7 days, the need for renal replacement therapy, the duration of mechanical ventilation, and the length of stay. Now, I will point out that in multiple trials conducted in Australia and New Zealand, the baseline mortality at 90 days in all of these trials have shown their mortality rates to be lower than 25%. Our ICU mortality rate is 15%, but then if you follow those patients out for 90 days, maybe it's around 25%. I suspect lower than that. So you really need a very powerful intervention to reduce mortality in a study like this. Now, the expected sample size was 8,800, and that would give a 90% power to detect an absolute reduction in mortality by 2.9%. That's a nearly 3% reduction in mortality purely from IV fluids. I don't know about that. I think that's kind of improbable. That means dropping mortality from what I think is pretty normal in Australia and New Zealand of 23, maybe 27% to 20%, maybe 23%, with a relative risk reduction of about 13%. The study size would have only had to be 5,000 patients if there was a 3.8% drop in mortality. That's a 16% relative risk reduction. So 8,800 if they were going to reduce mortality by just under 3%. But if it was higher than that, they might need fewer patients. So how many patients did they recruit? 5,000. Wow, that means they must have had an amazing result, right? No, they gave up after 3 years. Realistically, to obtain any results, the investigators needed to give a lot of fluid fairly quickly and see a demonstrable rise in plasma sodium and chloride. But that was not the case. Top left-hand panel, you can see where I've drawn 1.5 litres of fluid, and that is what patients got in the first 24 hours. It is not much fluid. In fact, I would say I give more fluid than this for most decent size operations. It is so little fluid to be giving somebody who is acutely critically ill. It's staggering. The other thing I want you to look at is the bottom right-hand panel that addresses open label non-study crystalloids that were received by each group. So this could be either saline or balanced salt solution. So if you put the two pictures together of all the fluid that the patients got, you can see that after the first 3 days, most of the IV fluid that was given was actually not the trial fluid. And in any case, on average, nobody received more than a litre of anything beyond day 3. Yes, you can see that there was a very mild rise in plasma chloride, but it did not exceed that scary number of 110 millimoles per litre. There was a modest reduction in pH between the groups, but the patients by and large started off acidotic, and we don't have a base deficit here, so all we have to work with is pH. If you look at fluids administered post-randomization, trial fluid was given 96% of the time to the balanced salt group, 96% of the time to the saline group, with a median duration of treatment of 6 days in each. The median volume was 3.9 litres versus 3.7 litres, balanced salt versus saline. And post-randomization, 63% of the balanced salt patients got saline. The saline patients didn't seem to get much balanced salt. So the mean difference in plasma chloride for balanced salt solutions was less than 2 millimoles per litre. The chloride difference between the two groups, it turned out, by my calculations, was roughly about 18 grams of salt, about 46 millimoles per day of chloride. How much is that? It's about 3 grams of salt a day. It's not been taken in over an afternoon. The body has plenty of time to excrete the slightly increased chloride load and indeed the hefty sodium load. By my reckoning, this salt difference between the two groups was about the amount of salt that you'd have in 6 chicken nuggets each day for a week. The other issue here, and this is on the top line, was the mortality rate was unbelievably low. It was 22%. At that level, I cannot imagine that any intervention, barring a miracle, would reduce all-comer mortality in ICU. But it's hard to fathom that based on this baseline number, that they believed that a 3% mortality difference was even possible. And remember, what we're talking about is giving bags of IV fluid containing salt, not arsenic. The outcome of this study is that there wasn't any real difference in outcomes for the patients, which isn't really surprising because there wasn't really any difference in the treatment that the patients got. If you randomize 2 groups of patients to IV fluids and then don't give them much IV fluid, how can you possibly think you're ever going to show an outcome difference? And so making a claim like this, that they found no evidence that the risk of death or acute kidney injury amongst critically ill patients in the ICU was lower with the use of balanced salt solution versus saline, I don't think this is a fair assessment of the study. What they should have said was that in a study where we give virtually no IV fluid to patients, we were not able to demonstrate that there was a difference between saline and balanced salt solutions. It doesn't disprove the null hypothesis. Now let's go to Brazil. This is the BASICS trial that compared balanced salt solution with saline on mortality in apparently critically ill patients. I'll get back to that in a couple of minutes. It was published in JAMA in 2021. It was a study of 75 ICUs in Brazil. The patients needed to meet criteria for ICU admission, which they listed as acute kidney injury, sepsis, mechanical ventilation, hypotension, etc. They were randomized if they needed a fluid bolus and were not expected to be discharged the next day. The patients were given de-identified bags of saline versus Plasmolite. The study was designed to enroll 11,000 patients. They actually enrolled slightly more than that, although this dropped down to about 10,500 due to duplicates and refused consent. Still pretty impressive that they got so many patients into the study. Their power analysis was based on an unbelievably high mortality rate of 35% at 90 days. In other words, they expected more than 1/3 of ICU admissions to die. This seems really improbable to me. 1/3 mortality at 90 days hasn't really been seen for a couple of decades in the ICU. But it actually gets worse, because if you look at the type of patients that were enrolled in this trial, nearly 50% of those patients had planned elective surgery. There's no such thing as planned critical illness. You're either critically ill or you're not. Just because you had a big operation doesn't mean that you're critically ill, because in that case, the ICU is acting as an extended recovery room. And we know from other studies that perioperative mortality now is extremely low, even for the highest risk operations. But there was also about 12% of patients who had non-elective surgery. So between elective and non-elective surgery, i.e. surgical patients, we have nearly 2/3 of the patients in the study where ICU mortality rates are really low. In the PLUS study, about 18 or 19% of the patients had come from the operating room. And now let's look at the fluid. So on the first day, on average, the patients got 1.5 litres of fluid, and during the first 3 days, the total fluid intake was 4.1 litres. Only 2.9 litres was actual study fluid. Remember, most people need 30 mils per kilo of water per day, never mind all the other electrolytes. To me, this is just very, very, very little fluid. And what's a little bit suspicious in this study is just how high the chloride was starting. It hardly changed, and it was really high to start with. And again, hardly any of the patients had a chloride that exceeded 110. You can see just scratch the 110 level in the saline group, but a lot of the patients who weren't in the saline group had chlorides that were closer to 110 than 105. A lot of pre-resuscitation took place. More than 1/3 of those patients received saline. Now when we look at the 90-day mortality rates, the saline group was 27.2, the balanced salt solution group was 26.4. So mortality was, unsurprisingly, significantly lower than expected. And remember, it had to be lower because 2/3 of the patients in this study had had surgery where the mortality rates would hardly touch 10%, even in the worst hospitals in the world, which means that the mortality rates in the medical cohort of patients would have to be spectacularly high to hit that 35%. And so the study was grossly underpowered just from a statistical perspective to show any difference. But of course, it's made worse by the fact that the patients hardly got any fluid at all, just like in the PLUS trial. There were secondary, tertiary outcomes, etc. One of the comments that was made in the study was that there was a high probability that the use of balanced salt solutions was associated with a lower Glasgow coma score, less than 12, for patients with traumatic brain injury that required mechanical ventilation at day 7. To me, this is hocus pocus. It's highly derivative data using statistical acrobatics. And although it's in the paper, it's not part of the conclusions. And frankly, I cannot see how a small amount of IV fluid with marginally lower osmolality could possibly increase the risk of death by 10%. I think this is totally anomalous, but people will quote this comment as if it proves that somehow or other saline is better than balanced salt solutions in traumatic brain injury. I don't believe it, and I don't accept it. When is a research trial not really a research trial? When you enroll thousands of patients into a study and then assign them to one intervention or another and then don't really give them that intervention. And that's what happened here. This is like a drug trial where one group of patients were supposed to be given one drug, the other group of patients another drug, and then the effects of these drugs measured. When the data was collected, you could make a claim whether the drug was helpful or harmful. In those circumstances, you needed to be sure that the patient actually got the drug. Certainly, there's no way the New England Journal would publish a drug trial that looked like either of these studies, because neither of these studies actually appear to have given the patient sufficient volumes or quantities of fluid and chloride to show any treatment or therapeutic or hazardous effect. At this point, it appeared that we had entered some form of endgame or Groundhog Day, where we would endlessly go around in circles having the same arguments about saline versus balanced salt solutions forever, because the research just wasn't good enough. But maybe there's a silver lining. Neither of these trials showed either a therapeutic or harmful effect, but they did enroll a large number of patients who could subsequently be utilized as part of a systematic review. Around the same time as the Brazilian study was published, the New England Journal Evidence, an online-only journal that has a smaller readership than the main journal, published a systematic review that looked at all of the data that had been published on the question of balanced crystalloids versus saline in critical care. This was a systematic review that looked at the question of whether balanced crystalloid reduced 90-day mortality in ICU. Eventually, they used only 6 trials that they felt had a low risk of bias. That included, though, nearly 35,000 patients. So they started off with 13 trials, and that whittled down to just 6. And these are the 13 trials, and most of the trials on fluids were in trauma studies that used a lot of fluid. The use of balanced crystalloids appeared to reduce all-cause mortality at 90 days. It also appeared to reduce the requirement for vasopressors at 28 days. And I find this useful because the signal in a lot of these studies seemed to support the use of balanced salt solutions in sepsis. There was also a mild signal to support the use of balanced salt solutions in preventing the development of acute kidney injury. The headline here was that there was an 89.5% probability that balanced salt solutions, that's lactated ringers, Hartmann's, sodium lactate solution, Plasmolite or Normasol, reduce mortality in critically ill patients at 90 days. Importantly, there is no evidence in support of the continued use of isotonic saline for resuscitation, except perhaps in traumatic brain injury. Finally, it's worth revisiting the BASICS trial. Zampieri and colleagues have done 2 follow-up studies that have looked at some of the problems that I identified with this particular trial, principally the issue of pre-resuscitation with saline, and also the fact that it was done in a lot of ICUs where some of those units had very few patients enrolled. And it turned out that when pre-resuscitation with saline was excluded and critically ill patients with sepsis were focused on, there appeared to be a fairly strong association with increased mortality associated with the use of saline. In other words, the mortality was reduced if patients were given balanced salt solutions from the start, but also they found in another study that even giving balanced salt solutions subsequently reduced 90-day mortality. There also seemed to be a benefit from balanced salt solutions for planned or elective surgical admissions. So in summary, administration of isotonic saline is associated with progressive hyperchloremia and metabolic acidosis. Saline is associated with significantly increased mortality in ICU compared with balanced salt solutions, particularly for sepsis, including pre-resuscitation. There is no published data that demonstrates that saline is safer or has better clinical utility than balanced fluids, particularly for diabetic ketoacidosis. Saline may be associated with worse renal outcomes versus balanced solutions. The declared outcomes of studies in IV fluids may be misleading, as often inadequate fluid volume has been administered. Follow-up secondary analysis of large studies have clarified the results. If you have only read the abstracts or indeed the papers of the PLUS and the BASICS trials and not followed up the subsequent publications, you may be misled into believing that there are no differences between saline and balanced salt solutions in critical illness, and I hope I have clarified these data. Thank you. So that's a summary of the literature on hyperchloremia and hyperchloremic metabolic acidosis. I hope you find it helpful and you're able to form your own opinions on this topic. It seems to me that large volumes of saline are likely harmful to our patients. As to whether a litre or two is harmful, I don't know, probably not. But when you look at these protocols, for example, for diabetic ketoacidosis that require patients to get 5 or 6 litres, you would have to wonder whether the doctors who write these protocols and issue international guidelines have really paid enough attention to the literature over the past 2 decades.